infection, a diarrheal illness, and they would be laid out and they would end up going to hospital and they would come back and they wouldn't be able to keep up. And then the same thing would repeat itself, and eventually they would start getting breathless and tired on very little exertion. He also noticed that when he measured their pulse rates would go up excessively high when they changed posture. So that was the first description of what we now know to be POTS. During the years from 1871, different people have called it different things. Some people have called it soldier's heart, some people have called it neurasthenia, some people have called it mitral valve prolapse syndrome, some people have called it positional tachycardia syndrome, and now we have this description or this definition called POTS. But basically, the typical symptoms in this condition and the typical symptoms by which people come to our attention is that it usually affects patients between the ages of 15 and 50. They're usually really well, high achieving in their lives, and they start getting symptoms. And the symptoms involve virtually all the different systems of the body when you look at it. But the common cardiac symptoms are they complain of palpitation, they complain of chest pain, they complain of breathlessness and dizziness. But when you ask further, and when you start looking in a broader setting, they will all complain of things like lack of refreshing sleep. I diagnose POTS not based on the fact that they're complaining of palpitations. I diagnose it when someone comes and says, I cannot sleep, I never wake up feeling refreshed. I'm always tired. I am tremulous first thing in the morning. I get frequent headaches. I get temperature issues. I'm sometimes very hot, sometimes very cold. I have gastric symptoms. I've been diagnosed with IBS. I get blurred vision. So those are the things that make me immediately think, these are the symptoms that make me think, oh, could this person have this condition that we know as POTS? Now, the first thing and a lot of people will also complain of this, where they find a bluish discoloration of their legs. 50% of patients with POTS will have this. Anyway, the question then is, what is POTS? Okay. What happened was, all these people over the years have gone to their GPs complaining of all those symptoms, but because all those symptoms are a bit non-specific, what does it mean you're tired? What does it mean you don't wake up feeling refreshed? What does it mean you feel a bit hot? It doesn't mean anything. One of the things that these people said, however, was that when I stand up, I feel my heart race, and I don't like it. So the doctors would say, okay, that's a tangible symptom. Let's send them to a cardiologist because she's complaining of palpitation. What the cardiologist did was, okay, let's see you stand up. And what they found was, lo and behold, when these people stood up, they didn't like it, and they also noticed that the heart rate went up excessively, more than 30 beats per minute. And so they decided to call this condition POTS, postural orthostatic tachycardia syndrome, meaning he stands up, doesn't like it, and the heart rate goes up a bit fast. And that's all it means, right? However, POTS, so at the moment, the definition of POTS is an increase in heart rate of more than 30 beats per minute if you're above the age of 20, okay, which is sustained for at least 30 seconds, an absence of a fall in blood pressure, and a frequent and chronic duration, meaning that the symptoms have gone on for more than several months. The problem I have with POTS is that it doesn't capture all those other symptoms that these patients complain of, which are not related to standing up, the lack of refreshing sleep, the gut issues, etc. How do you put it all together? You know, what we've done is we've looked at this one set of symptoms and given it this name. How do we encompass all these other symptoms? And when you look at all these symptoms, if you look very carefully, you will find that all these symptoms tend to be related either to disturbances in flight or fight, or rest and digest. So digestion problems, never feeling rested, and also heart rate going up, feeling hot, feeling bothered, brain, losing your head, all that kind of thing. So when you think about it, these symptoms, flight or fright and rest and digest, are autonomic symptoms, right? They're autonomic symptoms. So a better term is a disturbance in the autonomic system. So dysautonomia covers all of that. And I have rarely ever come across anyone who has POTS and doesn't have the dysautonomic symptoms. And if they do, then I'm thinking to myself, they don't have it. Whereas the problem at the moment is that most people wait for this kind of, they want the heart rate. Oh, your heart rate didn't go up. Well, it may not, but if the patient's got all these things, they've got a dysautonomia. How common is it? It's incredibly common. They say maybe up to 1% of the population in the US have it. 3 million patients in the US, ages 15 to 50, 5 women to every man. Okay? Why does it happen? The reality is we don't know. None of these descriptions tell us. POTS doesn't tell us why it happens. It doesn't tell us anything. Dysautonomia doesn't tell us why it happens. But I'm fairly confident that there is a genetic element, and certainly that has been identified, some kind of vulnerability that you inherit. And 1 in 8 people have a familial thing, okay? It may be a genetic vulnerability, it may be a concomitant condition which makes you more vulnerable, like EDS, Ehlers-Danlos syndrome, etc. And then something happens, and this is what a lot of people come and tell me. They'll say, something happened. I got pregnant, I had a perforated appendix which was not discovered, I had glandular fever. Some people talk about the HPV vaccine. I had a road traffic accident. And then after that, it was almost like I was hit by the flu, and I've never quite recovered. And then there are triggers which make everything worse. So wherever you are, these triggers will make everything worse. So menstruation will make things worse. Alcohol tends to make things worse. Intercurrent illness, and a lot of patients with POTS have impaired immunity. Intercurrent illness, so they tend to be very prone to this, and that makes it worse. Exercise can make it worse, and heat tends to make it worse, as does dehydration. Now, the way I like to describe a dysautonomia is this. You have the autonomic nervous system, and we're all nicely balanced between our flight and fright and our rest and digest. When someone comes and says, boo, we activate our flight and fright, our heart rate goes up, we get hot, etc. Right? We can't digest, we can't rest during that time when someone scared us, and then everything settles down. If 10 people come and say boo, you get a bigger response, and then everything settles down. The way to think of a dysautonomia is that the pivot has moved this way. Small triggers, big rises. And that is the fundamental issue with dysautonomia. The problem is that the more swings you have, the more the pivot moves this way. And that is one of the big problems. I thought we'd quickly talk about the physiology of standing up, because when we try and start thinking about what the causes are and how we go about treating it, or what the possible ways of treating it, you have to understand that this happens when we stand up. So if we could understand the physiology of standing up, maybe that would give us a clue, right? So here's a body, right? This is the blood, this is our brain, and this is our body. When we're lying down like this, the blood gets to the brain. When we stand up, ordinarily what would happen is the blood would get sucked down to the ground, right? So we would all have to be equipped with a bunch of reflexes to prevent this from happening, so that the blood can get to the brain. 2 things would normally happen. Our blood vessels squeeze the bottle to try and keep the blood up, and our heart rate goes up. And that is what happens in a normal response. So somewhere in that set of movements lies your solution. I'll talk you through the different types of POTS, because there's a lot of mention of, people have been trying to work out why is this happening? And so there's a group of patients, and these are not mutually exclusive. It's not that if you have one, you can't have the other. You can have a bunch of them all intertwined, but these are the things that have been found. The first is that people have noticed that patients with POTS have a reduced blood volume, so they have an emptier bottle to start off with. Around about 13 to 20% less blood volume. Okay? Now, why is that? And people have said, well, maybe it's because we have a problem retaining water. And when they look at those patients who have hypovolemic POTS, the way we retain water is by something called the RAS system. So when we become dehydrated, our kidneys sense it through some hormones. The kidneys absorb more water from our urine. That's why our urine looks darker. In patients with hypovolemic POTS, there's a problem with those hormones, so we do not absorb as much. That is one mechanism that has been postulated. Another thing that they have found is that patients with POTS have a reduced red cell volume. So not only do they have less volume of blood, but in that blood they have less carrying capacity, and that contributes to the problem. So that is hypovolemic POTS. The second is neuropathic POTS. Neuropathic POTS is basically something whereby they have found that in some people what you have is there's a problem with the ability to sense the stretch here, and thereby a problem with being able to squeeze. So they have this thing called sympathetic denervation. You cannot sense the stretch, and because you cannot sense the stretch, you cannot squeeze. And that is called neuropathic POTS. That is quite a common way to begin. Similarly, you can have similar things in the gut as well. The third thing is hypoPOTS, hypoadrenergic POTS. That's another form of POTS that's been described. In hypoadrenergic POTS, what they say is that you're producing too much adrenaline for whatever reason. Okay, so these patients, if you measure their adrenaline levels are higher than normal people, both when sitting down, when lying down, and when standing up. These people tend to really get an offshoot, an increase in heart rate. They tend to be the ones who get more tremulous first thing in the morning. And in fact, a manifestation of this extra adrenaline is their blood pressure actually goes up when they stand up. So those are the people who have hypoPOTS. Some people have this thing called norepinephrine transporter issues, where you produce all this adrenaline, but you can't clear it out. So a small group of patients have this genetic deficiency of being able to clear the noradrenaline. It all boils down to the same thing. You have too much adrenaline in your system. Mast cell activation, another thing which has been really, which is really interesting. Mast cell activation, let me tell you about mast cell activation. Very poorly understood. Okay, a lot of immunologists say that it's a controversial subject. Mast cells, if I take a knife and cut myself, my skin will become swollen and indurated, right? Why does it become swollen? It becomes swollen because it's a body's mechanism to allow our blood cells, our white cells, to come and fight whatever has caused the injury. So our blood vessels become leaky to allow that. This is mediated by these things called mast cells, which produce histamine. In people who have mast cell activation disorder, they're producing a ton of histamine, okay? And so what happens there is, if you produce a hell of a lot of histamine, then all our blood vessels become leaky, and we become deficient of fluid, which is the same as emptying this bottle. This is the issue behind mast cell activation. Now the problem is, how do you make the diagnosis? Often mast cell patients have flushing. They flush. They take something. If they're standing, they'll suddenly start flushing. And what you have to do is measure the urine within 4 hours of the onset of a flushing spell. And it's called methylhistamine per gram of creatinine. Unfortunately, no one does it. No one even knows about mast cell activation. And everywhere I've approached anyone, they say just give them some antihistamines and see what happens. I don't know. Then there is this element called physical deconditioning. Okay, it's really interesting because some people have said that physical deconditioning may be a primary problem in POTS, but may also obviously be a secondary problem. POTS can cause physical deconditioning, and some people say physical deconditioning itself can cause POTS. And the author of this paper was Benjamin Levine, who showed that patients with POTS have a 16% smaller heart size. So the heart actually gets smaller with deconditioning. Okay, 16% smaller size of heart, 13 to 20% less blood volume when you get deconditioning. And they thought, this is a picture of the Grinch. So someone postulated the fact that because these people had hearts which were 2 sizes smaller than normal, they called it the Grinch syndrome because the Grinch apparently had a smaller heart. But what was really interesting was this guy said, okay, if you put them through a training program, they found that they could increase the left ventricular mass by 12%, and they could increase the blood volume by 7%. This is Benjamin Levine, The Levine protocol is what Emma McKay was talking to you about. So he designed this protocol, which seems to work really well for people who are predominantly deconditioned. Then there's something called autoimmune POTS. Autoimmune POTS is where you have a virus or something like that, you develop antibodies to your own receptors. Those receptors may be to break down adrenaline, so they block the breakdown of adrenaline, or they could block your vagal hormones, the acetylcholine, and that could be another mechanism. Classification of POTS at the moment, people think about this as neuropathic, hyperadrenergic, but there's a developmental component which a lot of people sort of get out of as they get older. You know, when you have growth spurts, that can do it. In growth spurts, what's happening is the bottle is getting bigger, right? Virtually every patient, there are other things that can cause POTS, secondary causes, diabetes, alcoholism, autonomic damage, heavy metal poisoning. Those can also cause a POTS-like syndrome. What is really interesting is not a single patient that I have come across in my experience with POTS who has denied either anxiety or chronic fatigue syndrome. In fact, 40% of patients with CFS have POTS. Fibromyalgia, irritable bowel syndrome, hypermobility, depression. I always find that they will be very scared and intolerant of medications in general. I find that they have low immunity. Whilst we would like to think of them as distinct, they're not, they're all sort of combined. So what do I do when I get a patient? The first thing I ask is the autonomic symptoms. That's the thing that gives me the clue that they may have POTS. I think they should all have some blood tests, at least a full blood count, because they have low blood iron levels, they may have low blood volume, thyroid, electrolytes, B12, folate, iron, vitamin D. Virtually everyone with POTS has vitamin D deficiency. And there are autoantibodies, particularly if they complain of a very dry eyes or dry mouth. Sometimes I check the serum tryptase levels, which are a waste of time for mast cell activation, complete waste. And sometimes we check their catecholamines, urinary catecholamines, to exclude something called pheochromocytoma, which Dr. De Silva talked about, this adrenaline-secreting tumor in the body. But these patients have symptoms all the time. They don't have symptoms only in standing. But that's because doctors would rather look for the thing that is so rare and ignore the thing that is really common. They'll look for this. Anyway. I would normally do a Holter monitor because once in a while you'll see an SVT. Okay? So once in a while you'll see an SVT, and if you can get rid of that, that makes things better for the patient in general. As opposed to sinus tachycardia, where the heart rate rises gradually, here with an SVT, very sudden onset of this fast heart rate. The way to diagnose it is a tilt table test. You can see over here at the top, the patient is tilted up, the blood pressure doesn't really change, the heart rate doesn't change. Here at the bottom, as soon as the patient is tilted up, the heart rate rises, stays high, and then comes down. What is the optimal duration of tilt testing? Because that's really important, because people don't do it properly. The reality is, I have worked in the tilt testing department, and it's just the most neglected department ever. Oh, you can just go and do it. I have no training, I have no nothing. They just put a doctor there to make sure if the patient has a cardiac arrest, someone can do something. But we have no training, and there are lots of centers like that running tilt table testing department. Complete waste of time, bunch of cowboys. How do you, So one of the things to understand is what is the optimal duration? How long should you do the tilt table test for? That's important to know. And the heart rate generally goes up quite quickly. Over here you'll see that the heart rate goes up by more than 30 in about 3 minutes. Okay, so 75% of patients will get their heart rate to above that threshold of 30 beats rise within 3 minutes, and most 100% will get it to 7%, at 7 minutes. So 10 minutes is considered the ideal time. The problem with this, so the advantages and disadvantages, just to tell you, one other thing I wanted to tell you about is, so that's great. Now the question is, what about this active tilt table test, active stand test? Because a lot of people are very scared of having a tilt table test. They're not easily accessible. What about standing the patient up? Just lying them down, standing the patient up. The question firstly is, it is not a passive test, it's an active test when you stand someone up. They can do something, whereas passively they can't. And often what they do can interfere with the results. So they can squeeze, they can sway, they can do all those things. So you are much more likely to get a diagnostic result with a tilt table test as opposed to an active stand test. There are advantages of a tilt table test because it makes the diagnosis, and in some ways that is hugely important because it vindicates the patient. You know, it is so much easier for the patient if they have this label after spending their whole life being told that they're mad and they've got this and they've got that. To have a label is so important. And you know, I have diagnosed POTS without a tilt table test, and I have had GPs challenging me and saying, what makes you think that? Where's the evidence? We're not going to give him the medications you're telling him. There's no evidence. So making the diagnosis is hugely important. However, it's not easily available. It needs to be done in an experienced unit. It is uncomfortable, undoubtedly, for the patient. Taking medications before the thing may lower the diagnostic yield. What do you do if the tilt table test comes back negative? Does it mean it's negative? Does it mean you don't have POTS? The reality is, no, of course it doesn't. You know, no test. But the thing is, what do you compare it to? How do you know? So this is the gold standard, right? So you can't compare it to anything, so you don't know. It should be done in the morning because it's more likely to be positive in the morning. The patient may simply be having a good day, and we have to take that into account. It is not deemed safe in pregnant women, and for pediatrics, children, you know, again, common sense has gone out the window. If you're 15 years and you weigh, you play, you know, you're a hooker for the England rugby team, doesn't matter, you're 15, we can't do it. Well, anyway. Okay, let's go to management. Management is largely about two things, okay? When the problem is this, what you want to do is either you want to make the bottle smaller, or fill the bottle up, or stop the heart rate going up. Those are the three things. And that is what all management is about. The first thing I would say, it's important to educate the patient. It is really important to sit down. The number of patients I meet who will break down in tears the minute I tell them they have POTS. I say, thank God, someone believes me. Okay? Educating them, identifying and withdrawing anything that could make things worse. I dry the bottle or make the bottle too big. Diet, compression, sleep, stress, and exercise. In terms of education, it's important to tell the patient it is not dangerous, but it is debilitating. It has a huge impact on quality of life. It is a chronic illness. It should be managed by a specialist. It should have and the specialist should manage it in a multidisciplinary, holistic setting. Okay? Not good enough, oh, you've got this, go see a gastroenterologist in 6 months. No. Get a person who has a genuine interest in this. It requires intensive physician interaction. Most patients do improve over a period of time. However, it is never a straight line. It is 2 steps forward, 1 to the side, 1 back, 2 steps forward. Okay? And patients should avoid aggravating triggers and activities. I personally, as soon as they come, the one thing I do, which I think makes a difference, is I will write a letter for them. I will write to their employer. I will tell them, look, this person is telling the truth. You know, they are perfectly capable. Everything is fine. What you need to do is just make allowances for them, for what they have. And as long as you do that, you will have a much better functioning employee. I do that for university students. They get variable brain fog. They get unpredictable brain fog. No, timed exams is not the right way forward. Do this coursework. The last thing you want to do is stress a child out with all that as well, because they may get brain fog for 6 days on end. And they may have worked beautifully and worked really hard, and suddenly the stress of knowing what will happen to me on the day is incredible. So I do that. In terms of medications that can exacerbate POTS, antidepressants, SNRIs, venlafaxine will make it worse. Why? Because they are norepinephrine reuptake inhibitors, SNRIs. They stop the adrenaline from being uptaken, so they leave more adrenaline in the system. So monoamine oxidase inhibitors, tricyclics, antipsychotics, anxiolytics, diuretics because they dry the bottle out, venodilators because they make the bottle bigger, stimulants because they make the bottle spin harder. Right? Am I making sense?
Yeah.
Excellent.
So the first thing I would say is diet, okay? Let's talk about lifestyle. Diet's hugely important. You have to fill the bottle up. How do you fill the bottle up? You put more in, so you want to drink at least 3 liters a day. Put some salt in, because the salt will keep the water in you. A lot of patients with POTS develop a polyuria. They will just pass everything out. They develop a diabetes insipidus-like state. So keeping salt in your system is hugely important. Even better is taking some electrolytes, 1 to 2 sachets of dialyte a day. Drink a couple of glasses of water before you get out of bed, because when you suddenly get up, your adrenaline levels go up, you are now making that, you're causing the swings, your pivot's going to move this way. Fill the bottle up before you get up. Taking some magnesium is really good, helps you sleep, may make things a bit better for you. Correct any nutritional and vitamin deficiencies, avoid anything that dehydrates you. Compression, again, you're squeezing the bottle, you need the bottle squeezed. Okay, the reduced pooling increases the return to the heart. You want waist-high compression stockings, which exert 30 to 40 millimeters of pressure. You can combine them with magic pants, whatever they are. A lot of doctors don't know how to prescribe these, okay? There's evidence on the POTS UK website, but if you go to a lymphedema clinic, a local lymphedema clinic, they'll tell you how to do it. Sleep, hugely important. Every patient with POTS has disturbed sleep. In fact, everyone has disturbed sleep, but lots of patients with POTS have disturbed sleep. Some of the sleep disturbance is due to adrenaline surges. Dog barks, it'll cause an adrenaline surge in me, but it won't wake me up. Dog barks, you have dysautonomia, it causes such a high adrenaline surge, it'll wake you up and you will be woken up with a fast heart rate. So if you can stop the adrenaline surges, maybe you get a better sleep. That is why in the old days they used to give beta blockers in the daytime. Well, there's no point, because that just tires people out. Give them a beta blocker at night, suddenly it's becoming a lot more interesting. Avoidance of blue lights, a nice ritual, avoiding sort of horrible conversations with people which upset you, all that kind of stuff. Melatonin is a good thing, acupuncture is a good thing, painkillers. A lot of people with POTS have pain. If you can control your pain at night, we control our pain during the day. We don't think about pain at night, but if we can control our pain at night, we probably sleep better. Less adrenaline surges. Sleeping tablets are not recommended because they help you sleep. They don't allow you to maintain good sleep. Beta blockers, as I say, before sleeping, it's a good idea. Sleeping tilted, do you know why that works? Very interesting. Sleeping tilted? Okay, so sleeping tilted, when you sleep like this, right? All this blood that is down here is now being redistributed. So your kidneys will get more blood. The kidneys will think, oh, he's overhydrated. They'll produce more urine. Okay? So when you wake up in the morning, all the urine, all the volume in you is in your bladder. You feel so much worse. You sleep tilted, the kidneys aren't getting as much, they produce less urine, you feel better. Takes about 2 or 3 months. Okay? Stress. There's a vicious cycle that develops. Lack of sleep, fatigue, depression, pain. Lack of sleep, fatigue, depression, pain. You have to try and act on every component of that cycle. Stress makes everything worse. It is important that your doctor works with your employers to modify your working schedules. Psychological support is really important, and you should be encouraged to go and seek that. A lot of patients have spouses who just do not understand the invisibility of the condition, and it is important that we work with their family as well. Good pain control, holistic therapies, I'm all for anything that improves your quality of life. Exercise should be encouraged. Emma's already spoken to you about this. Benefits are seen at 4 to 6 weeks, but they need to continue to exercise even when patients are better. This is a nice study, the Levine protocol, where they found that actually if you put them under a regime of exercise, their heart rate comes down. You see the middle one is for the heart rate. Okay, so 3 months of exercise. But also, you will find that the social functioning quality of life improves with exercise. So no doubt exercise is really, really good. And also, here, the left ventricular mass improves with exercise. So your heart gets stronger, pumps more effectively, you get a more efficient system. What other management options are there? Pharmacological options. What are we trying to do? We're trying to fill the bottle up or make the bottle smaller, and we're going to stop the tachycardias happening. That's what we do. So in terms of blood volume expanders, we have fludrocortisone, which is a drug that we use. So I'll talk you through it. Desmopressin and erythropoietin. things that slow the heart down, beta blockers, and something called ivabradine. Sorry, 5 minutes? 5 minutes? Or quickly. And others, midodrine, mestinon, droxidopa, fludrocortisone, a steroid. Okay, it increases sodium and water retention, well tolerated, fills the bottle up. 50 micrograms is where I start, and I gradually build up to 200. Some people tolerate it, some people don't. Generally well tolerated. I can give you the slides if you wanted. Desmopressin. Desmopressin used to be used for bedwetters. Okay, spray under the nose. It helps you retain more fluid. That's how it stopped bedwetting. And we use that as a pill in the pocket. Good evidence that desmopressin decreases the tachycardia, improves symptoms. What we found, there's this study where they found that actually your heart rate fell by almost 20 beats per minute when you took TDADP as a pill in the pocket. Erythropoietin, because a lot of these patients have low blood volume, low hemoglobin in their blood cells, giving them erythropoietin is something that could help. However, the problem with this is that it is subcutaneously given, it's very expensive, it does have complications, so not everyone's using it. Certainly, I don't think anyone's using it in this country. But that is something to be considered. Beta blockers, propranolol is commonly used, it reduces the heart rate, but beta blockers do zombify an already zombified patient, and therefore they are not as well tolerated. And usually you have to give them in at least four separate doses, 20 milligrams QD. But at night they may have a real benefit, stopping those adrenaline surges. Here's a nice study where they compared exercise training with beta blockers. And what they found is that exercise training and beta blockers were equally good in terms of reducing the heart rate, but when you look at quality of life, exercise did much better than beta blockers, so it improved quality of life a lot better. Ivabradine, my go-to drug. This is an agent that acts on an electrical channel in the heart called the IF channel. F stands for funny, it's called the funny channel in the heart. It purely lowers the heart rate, it doesn't affect the blood pressure. It's generally well tolerated, it shouldn't be used with pregnancy, and it shouldn't be used with things like venlafaxine. It may cause phosphenes. Phosphenes is a sensation of seeing light where there's no light. So you may notice that, but not a big thing. And actually, there are again, very small studies. What we find is that if you take ivabradine, you find that the heart rate doesn't go up compared to if you're not on ivabradine. Okay, so IV saline infusion, really something a lot of people are very interested in. There is no doubt, if you give a patient who is really unwell, bring them in, give them a liter of saline or 2 liters of saline, they do amazingly well. However, there are no mechanisms in place to allow people to receive chronic IV salines, and a lot of people ask about these infusion pumps which are used in America. The problem with that is that there's a much higher risk of bloodstream infections with those, and therefore no one, as far as I know, is using them, and they're not recommended. However, someone has done a study where they brought people in for 1 liter to 1.5 liters of IV saline every 11 days, and that's resulted in a huge improvement. So this is a study that was done by these guys, Mohamed Roussier. Then there are other medications, clonidine. Clonidine is a centrally acting agent. It's not well tolerated in neuropathic POTS, but it may be good in hyper-POTS. It decreases the sympathetic tone, it stabilizes the heart rate and blood pressure, it reduces the orthostatic symptoms. Again, patients can be very sensitive, so you have to go very slowly. I've never used it so far. Sorry, are you almost done? 2 minutes?
We should have been done 20 minutes ago, Sanjay, otherwise we're going to charge extra.
Okay. Okay, just one, so methyl-dopa, same as clonidine, midodrine. Midodrine causes vasoconstriction, and again, effective, not as effective in hyper-POTS, more effective in neuropathic POTS. This is the agent I wanted to talk to you about, is pyridostigmine, mestinon, which I do use a lot of. Mestinon increases your vagal, your rest and digest hormones, and very well tolerated. It also improves gastric motility in those people who tend to be more constipated. And that's it. So eventually all I wanted to say is most patients do require medical therapy.